Acknowledge university and community supporters, University of Iowa's international programs and University of Iowa's honors program, which contributes time, talent, and logistics to this organization. I also want to thank the Stanley UI Foundation Support Organization for their financial support, and I thank today's special financial sponsors, Mason K. Braverman and A.W. Weltam Briscoe Insurance. Our programs are made possible by the financial support of these sponsors. So I'm pleased to introduce my friend and colleague, Carol Moss. She's a research associate at the University of Iowa Family Medicine program, recent graduate of the UI College of Public Health, receiving her MS in epidemiology, and she has a graduate certificate in global health studies. And the work you'll hear about today was done in part for that certificate. She's interested in alternative cervical cancer screening strategies in low-resource settings, primarily in the countries of Guatemala, Cuba, and Morocco. And she received a UI Global Health Studies Travel Award in 2015 to conduct work in Morocco, where she has had established ties for over 30 years. So please join me in welcoming Carol Moss.
Thank you, Dr. Squire. I also want to thank Ed Zestro and others in the Iowa City Foreign Relations Council and everyone here for coming today to this presentation. I'm really wearing my student hat today, so this is kind of the culmination of my, as Dr. Squire said, my Global Health Studies certificate. So the title of my speech, or my talk, is up here, Dissemination of the National Cervical Cancer Screening Program in Guernsey Province, Morocco, a Community Approach. Dissemination, for those who may not be familiar with that term, really, in this case, means the act of spreading something, especially information, widely. So that is what I was interested in learning about in Morocco, where, as Dr. Squire said, I have a long-standing relationship. I have this talk divided into 3 parts. I'm calling them chapters. I start out about 30 years ago when I first went to Morocco. Here is a map, a globe, a slice of the globe, and shows you where Morocco is. It is the northwesternmost country in Africa. It is very close to Europe, a very short boat ride across the Strait of Gibraltar from Spain. The area that I went to for this project is on the right slide in the box there, Guernsey Province, and I'll talk some more about that. Morocco is officially called the Kingdom of Morocco, and it's a country in what they call the Maghreb region of Africa. Geographically, it is characterized by rugged mountainous interior and large portions of desert. It's one of only 3 countries, with Spain and France, to have both Atlantic and Mediterranean coastlines. The Arabic name Al-Maghreb, which means the West, is also commonly used as an alternate name. Morocco has a population of over 33.8 million people and an area of about 172,000 square miles. Its capital is Rabat, though the largest city is one you may know, Casablanca. Other major cities include Marrakesh, Tangier, Tétouan, Fez, and Agadir. A historically prominent regional power, Morocco has a history of independence not shared by its neighbors. Its distinct culture is a blend of Arab, indigenous Berber, sub-Saharan African, and European influences, which also makes for a very unique cuisine. It claims, I'm sorry to say, the non-self-governing territory of the Western Sahara, which is located south of the country. Let's see if we can go back to that previous map. It is a part in blue just below the box on the left that, actually I think it's the part in green down there, but this is a part that Morocco has claimed as its territory, and this has led to some conflict. Basically, the issue is rights to the Atlantic. It's another water issue. I don't know if some of you were here to hear Sarah Mitchell last week, but another instance of water grabbings or access to water. Algeria, which is the country directly to the east of Morocco, does not have access to the Atlantic, and that is what the struggle has been over. Morocco annexed this territory, the Western Sahara, in 1975, which did lead to a guerrilla war with indigenous forces until a ceasefire in 91. Peace processes organized by the United Nations, though, have thus far, I believe, failed to settle this deadlock. So, and let me move ahead to where I think I was. Have we seen this one? All right. Morocco is a constitutional monarchy with an elected parliament. They have a king. He holds vast executive and legislative powers, especially over the military, foreign policy, and religious affairs. Morocco's predominant religion is Islam, and the official languages are Arabic, Berber, of which there are several dialects, and it's referred to as Darija, and French is also widely spoken. Morocco is an influential member of the Arab League and a part of the Union for the Mediterranean. It has the 6th largest economy in Africa. And I believe it has, the U.S. had the first treaty with, when it was once a nation, had become a nation, the first treaty it signed was with Morocco. So the U.S. and Morocco have very long-standing partnership. They currently work together in counterterrorism efforts, law enforcement to safeguard both countries' national security interests, etc. So these shots I have put up thus far are from this area, Guersif, that the project is located in. In Morocco, a lot of the income that anyone might have there is related to agriculture. Tourism is also a big part of the gross national product, and they have a lot of phosphorus. So that is their one natural resource besides the land itself that has given them an opportunity to rise in status in the world. So there are a lot of olive trees. There are some here. They do irrigate. Here's an example of just the irrigation from the local river that helps to grow the crops. They have a lot of other crops, a lot of oranges, different kinds of fruit, many vegetables, so it's very plentiful that way. So approximately 20 years after the first visit, I myself became interested in going back to school, and I started in the College of Public Health, the University of Iowa, in epidemiology. I went to a seminar led by Dr. Chuck Lynch, who is the head of the State Health Registry. I think he's retiring, but anyway, one thing he talked about was some innovations in cervical cancer screening, and I had a reproductive epidemiology class, and so my interest in that was started off. What I was so intrigued by was that there are still women in the world, even in our own country, who die of cervical cancer. Cervical cancer is a preventable disease, one of the few forms of cancer, if it's found early, that can be prevented. So I couldn't quite make sense of that, and that piqued my interest. So I learned as much as I could about it. We know now, of course, and this has maybe come out not that long ago, that The HPV infection is a necessary but not sufficient cause. Many of us in the room have the human papillomavirus in our systems, but we're able to fend it off. Some women, for whatever reason, are not, and they are the ones that, over a very lengthy period of time, may end up with a later stage of the disease that then, unfortunately, often will result in their deaths. As you see here, there are some statistics about 5-year survival rate. Those with distant spread only have a 15% chance of surviving. Here is a map of the cervical cancer incidence, or new cases. These are cases per 100,000 population in the world. This is a little old. It's from 2005. But Morocco is in the second lowest. It's still a problem there, but the red areas that you see, which are primarily in areas of South America and Africa and some, looks like Indonesia, they have the very highest rates at this point. And of course, those are pretty much in developing countries. And this also gives you an indication. You probably can't see a lot of the small print. The red is the incidence, or the new cases again. The blue is mortality. At the top, we have Eastern Africa, Western Africa, Southern Africa, South Central Asia, South America, and so forth. As you get to the middle, there are we are going down in development as we go down the chart. And at the base of it, among the more developed regions are the European countries, and North Africa is in there. So certainly Morocco does not have as high rates as some other parts of the world. So how do we deal with this problem? Now we have the HPV vaccine, which is also relatively recent in most people's lifetimes here, I think. That's the primary prevention. The next way to help, and that's what most of us do probably if we're female on a yearly basis, is have our annual exam and our pap smear, though the recommendations for that now don't say that you need to have it for some age groups as often as yearly. And then there are various treatment strategies if one is found to have some lesions. But when you deal with a low resource setting, especially one where there may not be a lot of water, they may have some difficulties with transportation. These are the women where the burden falls on them disproportionately. Developing countries, often rural dwelling indigenous peoples. The cost of the HPV vaccine in countries like this is prohibitive, and there really is no access in some cases to any cytology-based screening, which is basically, you take the pap smear sample and you send it to the lab. Well, there aren't labs there, so in some remote areas. This is a chart that expresses this. This is both in Ecuador and Guatemala. Ecuador are the bars on the left and Guatemala on the right. And it shows that there is a much higher proportion of women never having a pap test, not even once in their life, for the indigenous groups in each of these countries. Really about double in Ecuador and pretty much the same in Guatemala. So those are some pretty disturbing disparities between those groups. There are many barriers to preventing cervical cancer. In addition to lack of facilities or water, there are cultural and personal barriers, institutional barriers, just basic knowledge, attitudes, socioeconomic barriers. But when Dr. Lynch gave this seminar, I was very interested because there were a number of different ways that have been developed to help in these more remote areas of the world. The first one I learned about is a very simple one. It's called visual inspection with acetic acid. Does anyone know what acetic acid is? It's vinegar. 1,001 uses. Well, here's another use. There are lay people usually trained in developing countries to examine women. You take the acetic acid or the vinegar and you apply it to the cervix. If there is a lesion, a precancerous lesion, it turns white. So I thought that's great. Then there was an additional step added in some instances, and that is called the screen and treat approach. In that case, you apply the acetic acid, find the white lesion if it's there, and you remove it by freezing it, cryotherapy. Then, after that, in the last decade or so, there was an HPV DNA test that was developed to detect infection. So a number of countries have worked that into a schema where they may test women first to see if they're positive, if they in fact have the human papillomavirus in their system, as I indicated many of the women in this room do. And if they do, then they would perhaps direct their resources towards those women in particular to do the screening, since it would be a low-resource area. And then after that came several studies that sought to see if women could do the sampling themselves. And that has proven to be also a very viable way to make some progress, get some samples in, and then again, if it is a positive result, then there's still the burden of getting a woman to where she could have some treatment. Often, if the screen and treat approach is not done, that is, if you're only using the visual inspection with acetic acid, which I'm calling here VIA, one issue with that is even if the lesions have been identified, it often will require then, of course, another visit for the woman who may be coming a long ways just to get to where she had this first inspection done. And so, of course, many women don't come back and aren't fully treated in the end. So really an approach that really makes a lot of sense is the screen and treat approach. With any undertaking like this in a developed country, it's really important that you have partners. And I give a couple examples here. The first one is in the Latin American and Caribbean region. PAHO, I call it. I'm not quite sure how you pronounce that acronym, but it's the Pan American Health Organization. And they have done a lot. Their strategy is to reduce cervical cancer mortality and morbidity, improving capacity for comprehensive cervical cancer prevention. They do health education, screening, the precancerous treatment and palliative care, And then in this area in Morocco that I'm talking about today, they have recently linked with the International Agency for Research on Cancer, which is part of the World Health Organization. And just this past year, Morocco became the first country in Africa to be a part of this group. They have a lot of guidance from the international agency and help in getting their national cervical cancer screening program going, which has been going now for about 6 years. I'll talk a little bit more about that in a minute. Okay, so I had that interest. I had that ongoing relationship with people in Morocco from 30 years. I needed to complete my Global Health Studies certificate. I learned that Morocco had a relatively new national cervical cancer screening program, so that seemed like the perfect place to go and see what some of the people in this village where I visited many times knew about it. First, I'll talk a little bit about cervical cancer specifically in Morocco. It is the second most common cancer and cause of deaths in females. The age standardized rates are here from 2012. Incidence-wise, 14.3 per 100,000 females. This compares to 6.6 per 100,000 in the U.S. And then deaths from cervical cancer, 7 out of 100,000 females, compared to 2.7 per 100,000 in the U.S. Again, here is something talking about the National Cervical Cancer Screening Program, first implemented in Morocco in 2010 for women aged 30 to 49. That's been determined to be the span of years that it would make the most sense to do this kind of testing. And it utilizes the visual inspection with acetic acid every 3 years. Government pays for that. It's without charge to any woman who is in that age range. It's under the auspices of an NGO, which is called the Foundation Lalla Salma, or Lalla Salma is the king's wife. So it's basically a foundation that she has set up that does a lot of advocacy, raises money. It also supports a breast cancer screening component. And initially, I learned it had covered 5 of 16 regions of the country and was expanding to additional regions in later years, though I did not know if it had actually gotten to this part of Morocco where I was going to visit and where I had an established relationship. So I had a small project I developed through the Global Health Studies program. Went there for a couple weeks this past summer. Well, it was actually the end of August, I guess, beginning of the fall. And I just wanted to explore knowledge of the women in this area of the Foundation Lalla Salma and its purposes, as well as any, if I could get a hold of a primary care physician there, I wanted to see what that person might know about it. Since this is a very rural and sparsely populated province, I wasn't sure how many physicians I might actually be able to locate in a short time and talk to. I was able to talk with one, and then secondarily, just by talking about this with the women, I was hoping to kind of start a conversation, educate on some level what cervical cancer was, what cervical cancer screening was, what their possibilities were in the country to be screened. So here is a little different map of Morocco. Guersif is, well, Fez is kind of in the middle there, and then as you follow that highway going east, you go through Taza, and then you hit Guersif, which is the capital, or the regional capital of this province, this area. The province itself in 2014 had about 217,000 people. Guersif city is most of it. It's about 91,000. And the ethnicity here is they're primarily indigenous Berbers. The language usually spoken first is called Tamazight. It's one of the dialects. People speak Arabic as well. Some people speak French. Maybe there'd be 1 or 2 people who speak English. And fortunately, I knew one of the people who spoke English. And this is where I stayed when I went for my 2 weeks with this family. This was a relatively new home they built in this small village in the country. Obviously, they're quite a bit more well off than most of the other people in the village, which I'll show some more pictures of in terms of housing. This was the person who was my translator. I think it's translator. I always get mixed up interpreter and translator, but she did the oral translating of what I was asking. This is her kitchen. She's very proud of that. You have to throw in a cat photo because that's what we do now. There, she was enjoying, after having raised a couple adult females who are now adults, she is spending some time tending to cats as well as other animals in her village. This is a view from the top of their home, kind of gives you a feel for what the village looks like. There is a mosque in the background there. This is still part of their property and where some animals are kept in the structure there that they have set up. They also have areas in their, it's not connected to their house, it's a short distance from it, but where they keep livestock, they have a couple cows. Got some sheep. Another view. This would be more what the most of the homes are along these lines. So there'll be a lot of stones with a mixture of soil and small stones to keep it together. Since I started coming in the past 30 years, though, the first evidence of progress was the satellite dish, though, and those somehow cropped up everywhere. Even before electricity, it seemed like, was available in the village. They didn't have any running water when I first used to go here, but now there are wells, and there is electricity, and there is the satellite dish, and there are cell phones. So it's not exactly what it was originally, but certainly makes it much more for an easier life for people having to live there. A few more examples of what things look like in this village. So for my project, I was looking at an opportunistic sample of women, which ended up being 20, who resided in Guernsey province, and one primary care physician who is also an administrator. I surveyed them about their knowledge of the Foundation Lalla Salma and specifically the National Cervical Cancer Screening Program. And I tried to find out how they learned about it. And again, as I said, the female resident who was semi-fluent in English, pretty good. She's trilingual, certainly, in Arabic, French, and then the Berber dialect. She assisted with the identification of the sample and the interpretation. So first we started with some families who were in the immediate area of where she lived. Here we are walking. This is not her son. It's not her child. It's someone else coming with us, but we're going over to meet with our first group of people. And just to tell you a little bit about the sample of the 20, their ages range from 26 to 74. That leaves a mean of 41. And marital status-wise, most were married, though 3 had never been married, 2 were widowed, and 1 was divorced. Here is the interviews were conducted both individually as well as in groups. This is one of the groups that we talked with. The interpreter is the second from the top row on the right. And all of these women lived in this village except for the one that was second from the left in the back, with in between the 2 boys there. She was a relative, a sister-in-law, who was visiting the other women. So she is their sister-in-law, and she actually lived in an urban area near to the capital, Rabat. She was one of the only 2 who actually was aware of this program. So it was clear to me that the word had not reached this part of the country about the cervical cancer screening program. But it was great to be able to talk with her in the group setting, because just by her talking about her experiences with it, she had a neighbor who had undergone the screening, both breast and cervical cancer. And so the neighbor told her about it. She came back and told these women about it. So hopefully just by even introducing the subject, awareness is built, and the message will spread, and there will be more women who will be able to be screened. She told us that the way the country has set it up is in October. That's the month for screening. And if you are a certain age, she indicated you needed to be at least 45, but I'm not quite sure. I couldn't confirm that was the time when people would go and have the screenings, usually apparently in the more major cities. So it really has not gotten out to this area yet. So transportation, we walked to this group. There are other forms of transportation. Here's one. I'll show a little sequence of a woman getting ready to saddle up and go back to her nearby village. The saddle is one that has been woven by people in the area. So get the kids on, give them a little bit of a ride. Get her ready to get on. And off she goes. So another way that we got around was crossing rivers by foot. So another village, we followed this map, which you may not be able to see. It's fairly small print. But the main town where the other group lived was Safsafat, and then there are a number of other villages up or down the river, and we visited a couple of them. So we had a great hike. Here's one of the river that goes through that I just showed you on the map. And this was a group that we saw, a family. It was just the woman, there's one woman who was a participant. They have vehicles, obviously, as well in the country, so there is a car there. This is an example of a newer building. Here's the family that lives there. The woman was the participant. They had recently moved in from the city, Guernsey City, to the country, but they're from this area originally. Here she is making butter. I should have asked you if anybody knew what she was doing. She's making butter. In the olden days, well, 30 years ago, it would be a sheepskin, a sheep's stomach, I think, that they would use, not the stainless steel modern version, to do this for a really long time and change the milk into butter. I don't know if you can see on her forehead, she has a tattoo that is common with Berber women of that era. Could be on the forehead, could be on the chin. The boy on the right is her son, and he had a friend who was visiting from town. After we saw them, another day we took another trek down to another village down the river. This woman is also a participant, and her husband is there. He was the one seen earlier in the olive groves. I'm glad somebody laughed about that, because this kid in the middle, he had this thing which he put in his nose, and it was so funny. I thought it was like a piercing. It was very funny, but I still get a kick out of looking at him. You can't see the woman who is with the younger female there, but she was a participant as well. But the results of the 20 women, so 60% had heard of the Foundation Lalla Salma, identifying it as one that helps women who have cancer, not specifically women's cancers, but just helps women who have cancer. And of those who had heard of the foundation, all of them learned about it from public service announcements on television. Only 2 out of those 12, though, had any awareness actually of the cervical cancer screening program. And as I indicated, one was the woman who was visiting from nearby the capital city, and the other person was the youngest member of the 20. She's in her, I think, late 20s. So I needed to find that physician. So there was a man who was from the village who I had met 30 years ago, and turns out now he was in Guernsey City, which again is the largest city in the province, and he was now the administrator, the provincial administrator for health. So I arranged to meet with him. Did not know that my interpreter was not going to be with me, so had to really pull out the French from the back of the brain, and was successful in communicating with him on some level. Here he is. We haven't seen each other for 30 years. He did remember me, I'm glad to say. He had a lot of papers on his desk. So what did he know? Well, I had to interview him in French. He was familiar with the Foundation Lalla Salma. He knew about it mainly as his position in the Ministry of Health. He did not, in what I understood, indicate a specific awareness himself of the cervical cancer screening program, which was somewhat I guess I was somewhat surprised by that, but I found a recent published article from last year of a woman in Morocco who's been doing a lot of the statistics and following this program, and she also indicated that in remote regions, the physicians don't know about the program yet either. So there's a lot of word that needs to get out. He did talk a lot about championing the acquisition of a mammography machine while he was in his role. So, he's trying to do what he can. Conclusions from my small 2-week project. Nearly everybody interviewed identified the Foundation Lalla Salma as an organization that helps women who have cancer. Almost all the knowledge came from the public service announcements. The additional knowledge came from that neighbor who lived in a populated area. And it's pretty clear that the program has not been disseminated to the residents of this remote area. So there's still time. Hope I can have made some impact in visiting and bringing up the topic and engaging with the woman who was my translator. And a few lessons learned from this project. An established relationship with the trilingual member of the community was certainly essential. Again, the television PSAs seem to be a means to really get the message out. Pretty much all this I've said, but one thing I do want to point out is the prior awareness of local cultural beliefs was really critical to the success of this project. And a couple examples here. I learned from the interpreter that some Moroccan women have kind of magical thinking or beliefs about actually saying the word cancer, which they call serotan, out loud, or some will not want to say it inside their homes. So I didn't know that. It's a good thing that my translator, my interpreter did, because she could kind of moderate that and wait until we got outside of the building to bring up the topic. And so that did come up in a couple of instances. Another lesson learned, I did learn later that in French, though I did ask the physician about pap smear, he did not indicate he understood what I was saying, and I learned that in French it's sometimes referred to as FCV, which is an abbreviation for frottis cervico-vaginal. So maybe that was why he indicated he didn't know about it. I'm not sure. So, language issues. Some of the future recommendations, there need to be obviously more public service announcements specifically geared towards the cervical cancer screening program. Patient testimonials, people cited related to breast cancer screening, so those seem to be very effective, but not specifically on the cervical cancer screening part of the program. Obviously, we need greater training of the primary care physicians there, and I feel community involvement will be really critical to the success of getting women to participate in the screening program as time goes on. So generally, not geared to this project, but what are some future responses to inequities? We need to incorporate cervical cancer component in health interventions with women and girls. And then we have these new technologies that can be of use in these more remote areas. The pap smear in places where we can do that, we need to make that more widely available. Ensure access to the HPV vaccine, and there is a trial, I think, currently going on in Morocco, but again, the price is prohibitive for most. And then addressing some of the broader systems issues. And remember that the vaccine now, there's one also for the boys, and so let's hope that some individuals, as these two, will be able to protect themselves going forward, and the females they may get together with. And that's it. Any questions?
Do male physicians do the screening?
So I think I didn't mention this. The novel approach that Morocco is using for their national program is the visual inspection with acetic acid, not with the cryotherapy involved as well. But they have trained, they had a whole group of people that they took to India, where the physician who first developed this this procedure. They took them there. They are lay people. They could be nurses, but it's something that easily you could train lay people to do. So there is a cadre of women only who have been trained to do this kind of procedure. The question, though, do male physicians do the screening? Not that kind of screening, they don't. So they are limiting that to females at this point. When it comes to the mammography or the looking at the breasts, I believe that there have been some male physicians who are trained in that, but for the cervical cancer screening part of it, not at this point that I'm aware of.
Okay, let me couple of more general questions. Back to what you said at the beginning, Carol, that HPV is a necessary but not sufficient contributory factor. What are some of the other factors? And maybe we can go on to, do you have any statistics about HPV vaccination for girls in the U.S.?
I do not have statistics for girls in the U.S., but I know that it's lower, much lower than they would like it to be. I feel like maybe about a third of eligible females have gotten it. That's a real guess, though. I don't have definite statistics on that. They are trying to really encourage that. Maybe others have a better sense of that. And the first question had to do with, what was the first one again? Oh, HPV necessary, but no, yeah. Right. So I don't know that we really know. Certainly, there could be genetic contributions that lead some females not to rid themselves of the virus as readily. Certainly, environmental factors. If you come from a lower socioeconomic position and you haven't gotten good nutrition and healthcare in general, I would think that could contribute, but not a lot is known really at this point about why some women clear the virus in their systems, and that's most women, and why others don't. So,
this is also a more general question. Is an adult woman, if an adult woman has this cancer, is it more likely that her daughters will also develop it? Is there an inheritance?
That I cannot answer. I don't know if there has been found to be any genetic leak. I'm not familiar with that.
Okay. And back to Morocco, a couple of questions really asking the same thing. What are the cultural barriers? Can you speak a bit about those, and particularly the barriers for get diagnosed?
Mm-hmm. I can speak just from what I learned from the women who I visited with here. I can also speak from a paper that I read specifically for Muslim women who had immigrated to the United States about that, some of the attitudes. But first, concerning the women there, I think that with the woman who was the interpreter, she felt very willing to go and be examined and screened for breast cancer. She was a little bit less willing, even regardless of whether it was a male or female physician, to have the cervical sampling done. So that certainly is a cultural or societal barrier. In the recent paper that I read that had to do with the Muslim immigrants to the U.S., similar things were cited. Again, I think it's said in the Quran, and maybe others here know more about that than I do, that it's okay to have a health professional who is a male examine you. That's supposed to be something that is acceptable. Still, there was some in this article, quite a bit of resistance to the idea of the cervical exam. So there's a definite separation between those two kinds of screenings in the minds of the people who I talked with, and apparently others who were from the same religious background. Okay, well, do you wrap it up? Any other questions? Okay.
Yes. Are there any spontaneous questions? So it's my pleasure to give Carol a big thank you for her presentation. Carol, thank you very much. And I also want to acknowledge our sponsors, University of Iowa's International Programs, University of Iowa's Honors Program, and Stanley UI Foundation Support Organization, and again, today's financial sponsors, which is the Mason K. Braverman and A.W. Welt Ambrisco. Now we come to the special part of this. As a small token of our appreciation, we can present you with the coveted Iowa City Foreign Relations mug. Carol, thank you very much.
Thank you so much. Thank you.
Thank you all for joining us. We are adjourned.